Hello, welcome to the 8th in the series of Liverpool Responds. My name's Iain Buchan, I'm Executive Dean of the Institute of Population Health. And it's my pleasure and my honour to be joined by Dr. Sophie Wickham, by Professor Matt Ashton, by Professor Sally Sheard, and Professor Ben Barr to explore some of the work we are doing as a Department of Public Health Policy and Systems to help with the civic response to this pandemic from the University of Liverpool. For those of you watching on Facebook Live, there is a comment function where you can ask us questions, and there will be a session at the end where we will respond. For those of you watching on Zoom, please look at the little button at the bottom, the Q&A button, and use that to ask us questions that we will respond to collectively online and verbally at the end. We're all surrounded at the moment by a pandemic characterized by waves and inequalities. Waves of the virus that wash in and out in surges, that disrupt our daily lives, that disrupt our health services. But they're the direct biological effects. This department and this community look beyond that, at the social effects, at the wave that will come in the new year, sadly, of rising unemployment, the mental health effects of that, of the waves that will last a lifetime for the children born during a time of disadvantage and the effects that that has throughout the life course. The long-lasting effects. We ask ourselves, if Benjamin Disraeli was writing Sybil, A Two Nations in 2021, what would be the reflections on a series of waves that affect society unequally? The inequalities that are palpable in COVID-19 between young and old, between female and male, between Black and minority ethnic groups and others, between rich and poor, between North and South. So without further ado, I'd like to ask the experts on this call to share with you some of their observations on what is happening now and predictions for the future. First, in the footsteps of the first medical officer for health in Liverpool, a long public health history, we've had many noble directors of public health. Matt's an honorary professor in our department and Liverpool's director of public health, one of the busiest people on the planet at the moment, as you will have seen from the news. Matt, would you like to share with us your reflections?
Thank you, Iain, and morning, everybody. So, yes, very busy time for everybody right now and a really difficult time for everybody. And of course, overset all of that is our existing inequalities challenges that we face in the city. So I just wanted to put a few thoughts in right at the start around how I see inequalities and how I see maybe a way forward through some of this. If I may, and I know we know this, but it's just worth reflecting right at the start. So inequalities are differences between people or groups due to different factors such as social, geographical, or biological factors. And these differences may result in people who are worse off experiencing poor health and shorter lives. So in effect, this is about fairness and unfairness. Health inequalities are unfair and they need to be reduced. They must be reduced by the right mix of local and national interventions, both by government, but by all of ourselves as well. Inequalities in access to health and social care services is widespread and it's experienced by a broad range of different population groups. For example, low-income families, older people, those with disabilities, Black and minority ethnic groups, LGBT communities, but vulnerable people in general will experience worse health, and that simply isn't acceptable. So Liverpool is a fantastic city with an incredible tradition around public health, with an incredible community which often kind of comes together at times of crisis. But we are one of the most deprived authorities in the country, and that does come with significant challenges around inequalities and around health outcomes. So the health of people in Liverpool is generally worse than the England average, and that's despite the best efforts of everybody in the system. And to give a few examples of that, life expectancy at birth for men is around 76, and that's a 3 to 3.5 year gap with national average figures. And increasing, getting worse. People are dying that don't need to be dying. If Liverpool was a country of men, which is a strange analogy, but that would put us somewhere between the Czech Republic and Panama as an international comparison. Life expectancy at birth for women is higher. It's around 80, but there is still that 3-year gap baked in with national figures. And again, that gap is widening. And again, if Liverpool was a country of women, this would put us somewhere between Hungary and Ecuador. We also have big internal inequalities. So life expectancy is 11 years lower for men and 8 years lower for women in the most deprived areas of Liverpool, areas like Speke, Toxteth, Kirkdale and Croxteth, than in the least deprived areas like Mossley Hill and Woolton. And it's a very similar pattern for healthy life expectancy for both men and women, with both living on average with 4 more years of ill health compared to national average figures, and significant internal inequalities with almost a 16-year spread across the city for both men and women. And just taking you back to that fairness question, ask ourselves, is that fair? Is that okay? Is that acceptable? We have higher premature mortality rates for cardiovascular disease, for cancer, for liver disease, for respiratory disease, and so on. People are dying at an earlier age who do not need to be. It is simply unacceptable. We have high infant mortality rates, high levels of obesity in both adults and children, poor mental health and well-being, some shocking mental health figures, particularly at the moment as a result of the pandemic. So again, people living in ill health who just don't need to be. And we have a wider set of issues as well around poor school readiness. Over a quarter of our kids living in low-income families, high levels of long-term job seekers allowance, pockets of really bad air pollution, and many more, all of which negatively impact on physical and mental health, both now and in the future. And alongside that inequalities, if you overlay that inequalities frame against the pandemic, you can understand why the city has been so badly affected through COVID-19. So some of the modelling work that Ben and others have done through the university has shown that actually our levels of infection that we've seen through the pandemic have not been out of line with other areas, other parts of the country, but the outcomes as a result of those levels of infections have been. So we've had, in relative terms, the same level, but more people have died or have suffered severe consequences as a result. And again, that's just simply unacceptable. However, I don't want to be all doom and gloom about this, because I do believe this is within our power, within our gift, and actually within our duty to do something about it. We do have reasons to be optimistic. We do have in the city some fantastic natural assets and really good green space. We have a city with a wonderful history, fantastic traditions, cultures, tourism, at a time, perhaps not right now, but in the future and certainly in the past, architecture and our communities. If you think about our strongest asset being our communities, really strong communities with a strong identity, a strong sense of purpose, and a city that has massive potential to improve and to deliver. And I also think we've got a system that's there, a system that's ready and willing to work together, which is certainly what we've seen through the pandemic. People who are prepared to pull together, to work together at pace, at speed, in really, really difficult times to try and protect the most vulnerable members of our society and to try and improve health and well-being. There's loads of different reasons for inequalities. The Robert Wood Johnson Foundation model describes terms of health and how they fit together, and also tries to quantify kind of the element that each contributes. And there's other estimates out there, but broadly, this is around health status being 30% determined by individual behavior. So a big chunk by individual behavior, but by no means all of it. 40% due to the social determinants of health, 20% due to clinical care, and 10% due to the built environment. And this is important because sometimes we put the emphasis on the individual and it being the individual's responsibility to sort themselves out, sort their life out, and sort out any problems they might be having. And clearly that's not true. It's not just about individual behavior. It's about the system, it's about the city, and it's about everything that wraps around that. I just wanted to come up with some thoughts for what we could be doing, how we could be moving this forward. And there's loads of issues and not enough time ever, but school readiness is really important. We have to make sure our system, our maternity units, our health visitors, our speech and language services, our children and family centres, our parents and our communities, and the wider environment wrap around our young people so that when they reach school at the age of 4 and 5, they are ready and able to learn and develop. School excellence is incredibly important, absolute focus on attendance and attainments within our school system. And then that includes kids from outside the normal school system to help them realize and achieve their fantastic potential. And this is in relation to attainment, but actually it's much more holistic than that. It's if they are thriving, if our kids are thriving both physically and mentally, they will thrive from an educational perspective as well. We need a joined up approach to housing and to neighbourhood strategy. So with spatial planning, so people have good quality offers that they need and want in their local communities, high quality, affordable housing with good access to neighbourhood facilities and green spaces that help develop and sustain strong communities. We need strong pathways into employment and to help people stay in employment. And there's loads of work we've been doing in the city around wealth and well-being. So that's not just the economy at all costs. It's a really strong relationship between the economy and health, and both drive each other. We need a further push on volunteering, on community development, and on social prescribing to help our communities survive and thrive in times of adversity. And this is something that we've been working really, really hard on during the pandemic, really ramping up community resilience and community connectedness. And finally, we need to work together to ensure the places where we live, work and play are as friendly and as accessible for everyone, especially in later life and for those with physical or mental health conditions. And if we all do this, I think we are much more likely to have that healthy, happy and productive city. If I can conclude, I think some of this is not just about the what, it's about the how. How do we address health inequalities? How are we actually going to go about tackling these wicked issues? So firstly, systems leadership. This is all of our jobs. It's not one person's job to sort this out. This is about all of us understanding the priorities, getting the narrative right, truly owning them and delivering against that health inequalities agenda, mobilizing our communities. We need to be driven by data and intelligence, by evidence and insights, making best use of the data we've got available to us and developing new systems wherever possible so that data and evidence is as transparent and available. We need to embed prevention. We need to move our resources upstream and towards primary prevention and early intervention, not just tackling the problems we've got now, but the problems that are baked in the future. We need to adopt a proportionate universalism approach, and by this I mean a good offer for everybody, but make sure we are targeting that help and support to the most vulnerable members of our community so everybody gets the support they need. And we need to ensure systematic delivery of those interventions at scale and over a long enough period of time to actually make a difference. We need to have a plan and we need to deliver against it. And we need to keep on delivering, reporting on progress, making sure we're knocking it out the park and doing what Liverpool does absolutely best, which is protecting our people, protecting our communities and looking after people best they possibly can. A crucial element of that is learning from not just from success, but from failure and having those really honest conversations. So, Ian, if I may, that's where I'm going to finish. I don't think it sits with any one person. I think we've got a big challenge, but I do believe that if we pull our efforts together, we can do this. And that's not just in relation to inequalities as an ongoing agenda item. It's in relation to inequalities and how the pandemic has affected us all. Thank you.
Thanks, Matt. As a brilliant summary of the picture that we live in, unignorable truths, and you mentioned connectedness and community resilience. I think all of us, as many of us as academics have been redeployed into your service and public health service for parts of our lives, we're very touched by the generosity of spirit of Liverpool's people. It's profound, despite adversity. The way people pull together is incredibly humbling. Thank you. I'd like to now invite Sophie Wickham, Dr. Sophie Wickham, who's a Wellcome Trust Research Fellow in Public Health, to give us her reflections. Sophie.
Thank you, Ian. I'm just going to share my screen. Can everybody see that? Okay. So thank you, Ian. As Ian mentioned, my name is Dr. Sophie Wickham, and today I want to talk to you about Liverpool and the experiences of health inequalities in the North using some Liverpool-specific analyses and research done by colleagues here at the University of Liverpool. So today in Liverpool today, we see 1,300 more deaths compared to the rest of England. We have seen 13,300 more people living with a disability compared to the rest of England. We have seen 20,000 more people living with a mental health difficulty compared to the rest of England. And the image on the right reflects this, showing large mental health inequalities across England and focusing down on Liverpool by this box. So the red colours indicate worse mental health. There are over 31,000 children living in poverty in Liverpool. That's 1,000 more than the previous year and 6,000 more than 5 years ago. Perhaps what is more concerning is that these figures, they are not improving, they are not flattening, they are getting much worse. And the devastating impact these can have on families and communities is immense. But today is not today. These are 2019 figures before the pandemic struck. No one was reading these numbers out at daily press briefings. In fact, there was a deafening silence. These are not just numbers, these are people's lives, and the same devastating effect that we are now seeing with the impact of COVID-19 has been experienced for many years, with the same effect on families as people's lives were cut short. COVID-19 has shone a light on what many people already know, that health inequalities, these massive differences in health between people and places, have been a blight on this country for many years. England's regional health inequalities are now some of the largest in Europe. It is a true injustice that a child born in Kensington in Liverpool can expect to live 10 fewer years than a child born in Kensington in London. And this rises to 20 years if we think about life lived in good health. The image that you see on the right reflects an English train journey that you might take, and it reflects life expectancy for women along the east and west coast main lines. The further north you travel, life expectancy falls, and as you can see in the northern areas, the life expectancy is predominantly below the English average. But what is perhaps more concerning is that it is falling particularly fast for women in our most disadvantaged communities in the north. For the first time in decades, it has started to go backwards. So the image on the left shows the life expectancy for Liverpool and the rest of England. Liverpool is in red, and we can see that it is consistently lower than England's average from about 2003 to 2013, but it is rising. However, in 2013, 2014, it starts to take a downturn, and it hasn't stopped yet. Make no mistake, these differences in health, they are avoidable. So these differences in health are caused by differences in access to resources needed for good health. And we have done some specific analysis on Liverpool, looking at what explains those differences. So this image on the right shows the percentage of the mortality gap between Liverpool and the rest of England and what these are attributable to. So going back to Liverpool's 1,300 more deaths that we saw in 2019, analysis by colleagues within our team have shown that 35% is explained by living on a low income. 26% are due to environmental factors like crime, access to green spaces, and air pollution. 20% are due to employment status, and 18% are attributable to educational factors such as attainment level. Productivity, and by productivity I mean economic productivity, is lower in the north, and a key reason for that is the health is also worse in the north. So long-term health conditions lead to economic inactivity, and spells of ill health increase the risk of job loss and lead to lower wages when people return to work. Improving health in the north would lead to substantial economic gains. So analysis that we did for the Liverpool City region demonstrates that a third of this productivity gap between the Liverpool City region and the rest of England is due to ill health. and that if we reduce this observed health gap, we could generate an additional 3.2 billion into the economy. And that is just Liverpool City region. So if you take that out to the north and reduce the health gap throughout the whole of the north of England, by reducing this north-south health divide, this would generate an additional 13.2 billion into the economy. The cost of austerity is clear. Austerity-driven policies, these fiscal policies designed to reduce the government's budget deficit primarily through reductions to the welfare system and public spending, have played a key role in the health consequences we have been seeing and are now seeing. Funding for working age welfare benefits and welfare system fell by around 27 billion since 2010, and local government spending has fallen by 24% in the last 10 years. But these have not fallen evenly across the country and have not gone to areas of need. So the image on the right here shows the change in spending power per person for all local authorities services in England over the last 10 years. And spending power is a measure of overall revenue funding available to local authorities and includes council taxes and locally retained business rate. And this map shows that the deprived communities with higher rates of poverty and weaker economies in the north of England saw the largest reductions in their local authority budget. The message is clear. Austerity has cost lives. We have seen more deaths, more disabilities, more mental health difficulties, more children moving into poverty, a reversal in our life expectancy for the first time in decades. And this was still only 2019 before the pandemic struck. Thank you.
Thank you, Sophie. It's a profound and sobering picture of our starting point for the pandemic, a starting point of vulnerability, of vulnerabilities in people's health, their life chances, their livelihoods, but also the opportunity for large increases in health and the economy of the whole country. It's a big picture and profound starting point. I'd like to now introduce Professor Ben Barr, Professor of Applied Public Health Research, to take us through what COVID-19 has done from that starting position. Ben.
Thank you, Ian. I'll just share my screen. Thank you, Ian and Sophie. So, I mean, as Sophie has highlighted, in many ways, you know, the pandemic couldn't have struck at a worse time, with places in the north already made more vulnerable by austerity and with health already deteriorating in some of the most disadvantaged places and inequalities widening. So early on in the pandemic, of course, it was actually, you know, the more affluent groups that were affected. The COVID-19 epidemic arrives in the UK via people traveling back from Europe, people returning from their skiing holidays in France and Italy. But very quickly, this pattern reverses and the burden increasingly falls on the most disadvantaged. So once we take into account age differences, then in the first wave, we see that mortality was nearly twice as high in the most deprived areas compared to the least deprived. And that's what this chart from the Office of National Statistics shows on the left. And that's similar to the kind of differences we see in mortality from other causes as well, where we also see those large inequalities. One of the most dramatic inequalities that we see is with COVID-19 is the impact on Black and ethnic minority groups, who have consistently been shown to be at greater risk, both of infection and of the consequences of that, and sadly, death, as shown. This is shown in the graph on the right. And this is largely because of the existing inequalities that we have in this country that mean that people from minority ethnic groups are more likely to live and work in high risk environments, for example, being in overcrowded housing or working in essential occupations such as social care. And more disadvantaged areas, particularly in the north, such as Liverpool, as Matt has highlighted, were particularly badly affected in the first wave of the pandemic. Around 700 excess deaths in Liverpool between April and July, so there's 700 more deaths than would be expected from historical trends. And that's in all parts of the country saw this rise in mortality during that first wave. But that was particularly high in Liverpool, about 50% higher than you would expect from the national average. But these inequalities, this unequal impact of the pandemic, although it's predictable, it wasn't inevitable and could have been prevented. So we mapped some of the risk factors that were particularly associated with increased risk of death during the pandemic, mortality from COVID-19, including overcrowded housing, poverty, pre-existing chronic conditions and ethnicity, and developed a small area vulnerability index indicating, as is shown in the map on the left, those communities that are likely to be most at risk from the impact of the pandemic. And we highlighted back in June that these are the communities that will need additional resources in the case of a second wave of the pandemic in order to protect them from those adverse effects. Unfortunately, we're now seeing rising hospital admissions for COVID-19 within exactly those same communities that we had identified. In the second wave, again, initially we see infections rising fastest actually in some of the more affluent communities, but it is the more deprived areas and more disadvantaged groups that are experiencing the most severe consequences from this increase in infections. One of the most concerning factors is that at each step of the pandemic, the health and the social impacts have become more and more concentrated in the most disadvantaged groups. So these charts show what's happening in recent weeks. So we're seeing a large increase in hospital admissions that we see on the left, and in deaths from COVID-19 that we see on the right. But these are increasing far more rapidly in the more deprived local authorities, shown by the blue lines on those charts. So as I said before, at the beginning, in the first wave of the pandemic, mortality rates were about twice as high in the most deprived areas compared to the least deprived areas. In the most recent data that we have on deaths from COVID-19 in hospitals, we're seeing that rates are about 4 times higher in more deprived areas in the second wave of the pandemic compared to the more affluent areas. So already in the second wave, we're seeing levels of inequalities that are nearly twice as large as they were within the first wave. Of course, there are huge concerns about the unequal impact of the control measures. And we are seeing from this work in the Resolution Foundation that in the most deprived parts of the country, 1 in 5 workers in those places are still not working or furloughed in September. So we do see this unequal impact of the economic effects of the control measures that are also potentially going to exacerbate those inequalities. But with hospitals in Liverpool already at breaking point, there is only one way to prevent these unequal economic impacts, and that is to control the virus. So what needs to be done? I think there are 2 crucial things that I'd highlight that Matt has also mentioned. Firstly, we need to ensure that actions are proportionate to need. So there are large amounts of money have been put into centralized systems that haven't been able to adapt to local needs and to support the local response. And while some funding has gone to local authorities, that hasn't been sufficient or sufficiently taken into account differences in need. So the interventions that are there, like mass testing and contact tracing, need to be targeted and resourced so that they maximize their effectiveness in the communities that are most at risk. The map there that shows the percentage of contacts successfully traced. And to address these inequalities, that would need to be more effective in the most vulnerable communities. But at the moment, we're seeing the opposite to that. So secondly, we need an approach that is tailored to the communities most at risk, led by local government in partnership with those communities and informed by granular intelligence, so that we can respond rapidly when problems arise. And that is exactly what we are working towards in Liverpool. Thank you.
Thank you, Ben. Extremely sobering increase in already profound inequalities, but as you say, not inevitable. We must take proportionate action, and we must keep looking at the size of these inequalities and the size of response in policy terms that is appropriate. So it's my great pleasure to introduce Professor Sally Sheard. I see Andrew Geddes and John Rankin, Professor of Modern History, Wellcome Trust Senior Investigator, and the head of our Department of Public Health Policy and Systems. Sally, may I invite your policy reflections on this state?
Thank you very much, Ian. I'm just sharing my screen so I can start my presentation. What I'd like to do for the next 5-6 minutes is to broaden the debate and encourage you to think about how we learn lessons from pandemics. We have a long history of pandemics in Britain and internationally, and this won't be the last, I'm sad to say, but the good news is it will end at some point, as previous pandemics have done. They have been regular visitors to the UK for hundreds, if not thousands of years. This is a cholera cartoon from the 19th century when we had frequent arrivals of cholera. But historically, we had temporary responses. When these frightening diseases appeared in Britain, we would put up local temporary boards of health, and national governments were very reluctant to get involved. And that took a long time to change. And one of the key things that really prompted big change was the last big influenza pandemic of 1918-19. And this has been featured a lot in discussions over the last 10 months. People have gone back to this to look to see whether there are lessons that can be learned. And it's probably a bit too naive to think we can look back 100 years and make direct comparisons. That's very hard to do. But what we can do is to look at how we coped with it then, where there are similarities and differences, and see if there are system learning points. We know that in 1918-19, it infected over 500 million people worldwide, and that about 3 to 5% of the world's population died from influenza. It happened over 3 waves of infection, and we're seeing a wave pattern with the current COVID pandemic as well. There was then no effective vaccine or treatment, and there was a very slow national response in Britain. The chief medical officer of the time, Arthur Newsom, was subsequently criticised because he had hung back and not intervened when he had been told by local medical officers of health. And that tradition had been set up in Liverpool in 1847 with our first MOH, Dr. Duncan. He hadn't listened to the local medical officers and their knowledge about what was happening in their communities. So if we look to Liverpool and what Liverpool did in that influenza pandemic of 1918, we know that patient 0, the first case, arrived by ship from New York. We know that there was a very clear impact on the poorer parts of the city, in the overcrowded rental housing around the docks. In that pandemic, we had 2,551 deaths, direct deaths that were recorded as influenza deaths, but we also had a lot of deaths from related diseases. And most of those diseases we can directly relate to the poverty of those individuals. So bronchitis, pneumonia, deaths caused by living in poor quality housing, having insecure income, poor quality diets. The medical officer of health at the time was Dr. Hope, here on the right, and he had a much more proactive local response than the national government. He closed places of entertainment very quickly. He closed schools for 2 months in October 1918, and he advocated wearing masks. It's important that we learn not only from the pandemics that we know happened, but what we can see as the near-miss pandemics, the ones that didn't happen. The case of this was Liverpool in 1951, when we had another outbreak of influenza with a very sudden onset in winter that peaked in January 1951, when there were 894 deaths in the city, the highest ever recorded total since the cholera outbreak of 1849. That pandemic lasted 6 weeks and there were over 3,000 deaths. And normally we'd see around 1,000 deaths at that time of year. The lessons that were learned from that pandemic were that we needed well-resourced public health departments with strong leadership. We needed to have capacity in district nursing and social care, particularly through home healths. And we needed to have contingency planning and liaison with the NHS. Liverpool has been doing mass testing for a much longer time than you would imagine. We pioneered mass testing in 1959 for another infection, this time for tuberculosis. And again, please think, this is before the internet, this is before mobile phones, this is before most people had phones in their homes. We managed then, over the course of 8 weeks, to do mass X-rays for nearly 500,000 people. We uncovered a significant number of asymptomatic cases of tuberculosis. How was this done? It was door knocking, it was leafleting, it was using volunteers to go into communities. As you see, Andrew Semple, the medical officer of health here, talking to women in Liverpool, persuading them of the benefits of having a mass X-ray, even if they felt completely healthy. And this is what we need to capture now when we enter our next phase of response to COVID-19. There are some important things that we can understand from history. The importance of where we put our public health resources, the importance of having them at the local level, but also partnered with a national pandemic response service. And we've changed considerably how we've organised that in recent years. We've gone from a public health laboratory service to a health protection agency. And when we've had previous pandemics, such as 2009 with swine flu, there were some significant lessons that came out of that. We didn't have an effective containment policy with good local liaison. We had confusion over communications, lack of clarity over who was leading that pandemic response. And we possibly had an over-reliance on modelling and not enough use of serology and public health surveillance, which the local capacity had been diminished significantly. That local public health has been subsequently cut further. In 2012, we had the setup of Public Health England. Public health was put back into local government, but with ring-fence budgets, which was subsequently significantly cut. Really quite substantial cuts in public health staffing at local level. So, as I said at the start, pandemics return. We know that this won't be the last. What lessons can we learn? We do need inquiries, but to flag up for you that we have repeated inquiries. We've had 68 major public inquiries since 1990. They've cost £638 million, but there is no routine policy for implementing the recommendations. We need to get better at learning, not only from history, but from the inquiries that supposedly draw on the history. We need to get better at improving our institutional memories and learning from individual experiences as well. We know we've had a great line of medical officers of health, from Dr. Duncan through to our directors of public health, Matt Ashton. They need proper resourcing. And we can see from 1918, from 1951, that when we give local public health the appropriate resources and we match it to the health conditions in the local areas and acknowledge that infection diseases do cause proportionately more suffering for our poorer communities, that's when we will know that we're properly addressing pandemics. Thank you.
Thank you, Sally. So it's always remarkable to reflect, to look back and realize that the most important predictor of the future is the past, particularly how we behave as individuals and as society. Through the organized efforts of society into a future that's an increasingly connected world, like we're gathered here on social media. We can self-organize in new ways. So how can we look forward? How can we avoid the currently greatly avoidable adverse consequences of COVID-19 through the organized efforts of society? Many questions have come through. I'd like to thank all of the speakers here for an excellent series of talks that have provoked a number of questions. Ben, there's one question here about the ethnicity and how much is down to ethnicity per se, how much is down to the association between ethnicity and deprivation, etc. I wonder if you could take us through the actual attributable fractions that we've been exploring.
Yeah, thanks, Ian. I think it's a really good question, and the one that comes up frequently when we're talking about ethnic inequalities in relation to COVID-19. And the Office for National Statistics has done some analysis looking at how much of the difference we're seeing between ethnic groups is explained by these other kind of socioeconomic factors, because it is the case that people in minority ethnic groups are more likely to be living in sort of worse housing conditions and employment conditions that increase their risk. And that analysis generally shows that does explain quite a large proportion of those differences that we're seeing. I can't remember exactly what the figures is, but I think it's about half of the difference is due to these other sort of social and economic factors. But of course, we need to think, why are those social and economic conditions worse in those minority ethnic groups? That says something in itself about the inequalities and the injustices that are in society that make some groups more vulnerable to this pandemic than others.
Thanks, Ben. From Facebook, we have Kathleen asks us about peer coaching networks. How can the communities really self-organize? How do we tackle the things that are heading to us like a truck, particularly amongst younger people, creating more opportunities? Matt, maybe you could give us some of your reflections on how communities are self-organizing and what more they could do if they were better resourced to do so.
Thank you. So I think this follows on from Sally's excellent point in her presentation around, resource locally, don't resource nationally, give the money and the investment to the people in the local area who understand the problems, who understand the systems and understand the solutions. So I absolutely think we should be supporting local investment on a much bigger scale. There are obviously issues with that nationally at the moment, both in terms of the amount of money that seems to be available, but also in the way that it is distributed. But nonetheless, we absolutely should be investing in the people who are able to make the biggest difference. I think, as I tried to say in my opening remarks, a large chunk of this is around community activation, and that's community activation, absolutely, with the resources that people need to do it. You know, the community activation doesn't come for free, but it does come a hell of a lot cheaper than some of the other kind of commercial contracts perhaps do. So there's absolutely my view absolutely is that we should be investing in local, investing in the people who are able to make a difference. I think without knowing the detail of the coaching question, Ian, sorry, it feels like that's the right kind of approach. I think what we also have to do is build in those learning loops as well, though. So there is great experience nationally and internationally around how we can, support people, and we need to have a localized approach, but drawing on expertise from elsewhere.
Thanks, Matt. Andy Pennington asks us to reflect on debt at the moment. There's vicious circles opening up, particularly as we have rising unemployment, economic impact is hitting, and there'll be timing issues. We don't want to be too late to be able to help, but to be able to help, we need to marshal resources in a macro and a microeconomic way more. So, Sophie, do you have any reflections there on that?
I definitely agree with Andy. I've not done any immediate analysis on this, but we definitely need to be seeing at a national level what's happening to people's debt as a response. I don't know whether Ben or Sally have anything to add.
Yeah, I mean, I think it is a huge issue, and we know that debt has a fundamental effect on people's mental health in particular, and that unsustainable debt has been increasing during the sort of period of austerity, and is going to be particularly affected by the pandemic and the economic effects of that. Of course, debt is quite a difficult thing to kind of measure and assess. You know, the people who have some of the biggest debts as some of the wealthiest people. If you've got debts, if you owe the bank all the millions of pounds, then you basically own the bank. But it's the debts that people face in their day-to-day lives that aren't sustainable that really have that sort of negative impact. If
we think about the evidence from people moving on to universal credit as an example, there's quite a bit of research out there, qualitative research, that looks at that weight for first payment. So people moving into debt as a cause for mental distress, as Andy's mentioned. So we know it has an immediate effect.
Ian, just a thought from me as well. There's short-term and longer-term solutions to this as well. So the short-term solutions, obviously, around kind of debt advice and proper citizens advice for people who are in debt problems. But the longer-term stuff is around having an economy that rewards people appropriately for their efforts, and that includes then best start in life, educational attainment into full employment, and a healthy, functioning economy that gives people reward for their efforts.
Thanks, Matt. So taking that learning loop, we've got to be able to chain together these potential investments, mitigate risks in the short term, but create opportunities for that self-organization, for homegrown solutions that our audience have pointed out in the longer term. This is an opportunity, sadly in extremis, to rethink, to regroup, to make proportionate action, but with greater alacrity. So targeted in the right way to the right people at the right time, joined up and continuously learning, which if we look at the past, many of these actions have been too blunt and too slow. A rapid action being put into place at the moment that many of you will have read from the news headlines in the last 48 hours is mass asymptomatic serial testing. The rapid turnaround testing deployed to large numbers of people in the community who do not have symptoms. And we've been immersed in this as a public health professional family. We are immersed in thinking of what we do now, but what are we doing for those homegrown solutions? What are we doing? What extra benefits can we buy for our population's health and their social well-being? Into next year and beyond. So there's a lot talked about release, and I think I'll ask Matt to reflect more on this, but yeah, I was pleased to see that a lot of the headlines have used that word release. Can we release individuals from isolation in smarter ways back in to the activities that are part of the important social fabric that we need to keep that community cohesion, that are important for protecting our economy in perilous times. So Liverpool is embarking on a prompt, proportionate response that is a journey of discovery and an opportunity for smarter release for individuals and for communities through better use of testing. And Matt, do you want to give us any of your reflections as the accountable officer for this?
Yeah, so I think this is a really exciting opportunity, and it is wonderful, again, in Sally's presentation to be reminded of history and reminded of the tuberculosis case finding in 59. So there's loads of kind of historical learning and there's kind of culturally relevant stuff going on here. But obviously, right in the middle of a pandemic, it is incredibly important. Even though we have decreasing rates of the virus locally, they are still very high, and our hospitals are under incredible pressure. So it's important we do everything in our power to suppress the levels of the virus. The traditional testing has been, if you've got symptoms, you go and get tested. This is on a much larger scale. As Iain says, it's asymptomatic testing, so it's for everybody. It is not mandatory. It is not an enforced screening program. It is a voluntary asymptomatic case finding exercise that will do a number of things. Actually, it will help us understand the virus to a much greater extent in the city and allow us to target our resources appropriately. So that's to the public health community, that's enormously valuable. But for individuals, of course, it will help to identify your personal status, whether you are positive or negative. And if you're positive, and this is kind of like the downside of it, if you like, if you're positive, then there are certain responsibilities people have. They need to self-isolate because that stops the spread of the virus. And that's incredibly, incredibly important. But it is an imposition on somebody to ask themselves to self-isolate for a period of time. And where Iain is talking about is the smart release stuff, which is the benefits of knowing you are negative. So this is not just about building our testing capacity and undertaking a research exercise. And it's not just about building our testing capacity and hoping people will turn up. This is really building this from the ground up, a community-led initiative, hopefully community owned, with strong comms behind it, where people understand the value of us and of them understanding what's going on with the virus in the city and taking control of their individual and our collective destiny. So actually, if we get this right, and there's so much work going on into this right now at pace, if we get this right, we will have large-scale asymptomatic testing in place by the end of the week that allows people to understand where they are with the virus. And if they're positive, then self-isolate and break those chains of transmission. But if they're negative, potentially opening up some freedoms and flexibilities that perhaps people would not have otherwise had. So that's the kind of the motivation piece in this. And the goal then is, because this is a brilliant opportunity right now with national lockdown due to come in on Thursday, the goal then is to do this intensively over the next month, that allows us to exit out of that national lockdown in a much stronger position. So it's really, really exciting, but with lots and lots of work to do, and absolutely one that needs to be understood and owned by our communities. And for me personally, that's very much the approach we took during the Prince's Park outbreak, during the summer, during August. This was not something we were moving in and imposing on people. This was activating our communities and helping them take control of their individual and collective destiny.
Thank you. Thanks, Matt. So we're asked by one of our audience here, why can't you just send a test kit to every household in Liverpool? I'd say an enormous amount of work is being done as the technologies, the logistics, the communication. Many things are possible, but technologies alone, a test is nothing without community. The community here can create homegrown solutions. All of the great ideas that are coming through, we will work out what works as we go along. We will create those learning loops. The best public health is embedded in communities, not prescribed from afar. Liverpool has a very, very long tradition of dealing with problems with nobility and with community. And Liverpool Responds is about feeding the university's civic role, the science and the art of public health, of learning from the past, of responding to the challenges that arise at a few hours' notice. But we can respond. You've heard some of the responses here today from Matt, from Sophie, from Ben, and from Sally, as one family of a Department of Public Health Policy and Systems at the Civic University of Liverpool. And I would like to thank you for all of your questions. There'll be many more matters arising in the coming days, so please keep an eye on our websites. Keep that community conversation going. Keep thinking of what is possible in terms of self-organization. And we are always listening as a public health service, as public health science, and as the University of Liverpool, responding with the people of Liverpool as one. So thank you for taking part. Thank you for listening. Keep safe and keep optimistic. Thank you.